First of all, I thank all of you for allowing me to come here, and I see a lot of familiar faces in the crowd. And of course, over the years, my office was at St. Mary's for many years, and I've had a very close relationship with members, faculty, and just the people over here at the seminary, and just it's been a very blessed type relationship, and I've much enjoyed that. Jeff called and left a message, and the topic was to be on end-of-life euthanasia. And of course, as a physician, when you see that, I think I was as a Friday afternoon, evening. Fridays are not really good days in doctors' offices if you want to come in there because it's so busy. Everybody wants to get well from last week, and so they can be on the weekend. They're going to be better. But I looked at that at first. I thought, oh no. I said, that's kind of a slippery slope. I can put my foot in my mouth real quick there, but it's a. But I looked at it as the topic here says, physician approach to end-of-life care, challenges and opportunities. First of all, I put end-of-life care in principle. I think that, I look at end-of-life, of course, I'm a Christian, a strong believer. End-of-life, that's the end of the physical sort of life into spiritual life. So it's through, the end-of-life is really, I think, sort of a misnomer. And I think as we get into the dying process, I think that the end-of-life and death is a very important part of that chapter in life in which we enter into another chapter of our being in life spiritually. And it's a challenge and opportunity. As physicians, we want to help people. We want to make them better. Well, I look at death, people dying, and how we can do things better. That helps people, the dying process with family members. I'm on call, so let me just make sure I get this. I'll turn this. Okay, so it won't go off again. So anyway, it's an opportunity for me, it was the challenge of doing this and an opportunity for me to look at myself, to look at how I approach death, how we look at death, and certainly I've seen many people die, and it's sad when you take care of people a long time, but then again, I'm going to have 3 presentations of actual cases that I've taken care of over the years, and how they presented and how they folded out and how they were handled in good ways and terrible ways and bad ways. And it talks about our end-of-life. And I'm going to talk a lot about what we have available now and how we can improve the methods of dealing with end-of-life, and as opposed to maybe going into what is happening in the States here as well as abroad in the country or the world in dealing with death. That is a very debatable, controversial area. So anyway, our goals as a physician were to provide high-quality end-of-life care. We want to give good, high-quality life care and end-of-life, and we have opportunities to do this. We've been rather poor in how we deal with end-of-life. Again, the discussion, early discussions, talking about it because it's reality, and certainly, and we need to get better communications. Communicating with our patients, explaining to them. There's a SPIKES. There's an acronym called SPIKES, and settings and perception, and that stands, but you can Google it, and it talks about how we can deal with patients in the dying phase, and it's very good communicating skill. We need to listen, as we've always, in the teachings we need to listen more than to speak, and that allows us to listen to the patient. And we need to utilize resources we have available now. We have so many resources now, that are available. And the palliative and hospice care, I'm going to talk a little bit about that because I really am a strong believer in that. And we can do a lot better. We have not done, as physicians, a very good job in getting people in early. The last 3 days of life or in the ICU, we talk about this. In the hospital, we need to be talking about this earlier because we can do so many good things for the patient and the family. And we have there's something you can Google this. It's called Life Choices, and it's and this is not politically advertisement for the Attorney General Chris Koster, but he has put this together, and you can Google this, and you can get copies of this sent to you free. And it approaches everything from your spiritual views of your funeral, how you want it set up, who you want to talk with, and it talks about advanced directives, which are so important. And what you do and what you don't want, because to have that outlined before you get in this end-of-life event phase, it's good to know your family knows having a medical durable power of attorney. These are things that make things so much easier, so much better, and it just gives everyone a directive at that time. But it looks like this. Uh, as a physician society, we want to give the basic, provide good in a dying patient, provide good basic medical and comfort care at its best. Pain controlling for the dying, and we'll talk about at the end of life how patients perceive what they want versus what the public might perceive or the family, but they want different things, that comfort, that pain control. And we need to be, at the end of life, we have emotional issues, we have spiritual issues, social issues, along with the physical needs of pain control at the end of the life. It's a shifting of how we treat things in that last, 6 months or last few days of life. And also we need to talk with families and have the families educate them. And I put this in there, be a better steward as we spend $210 billion in the last year of life. And they've done studies and they feel that it's been wasted. This is the physician treatment, ICU care when we can't do anything for someone. We're just, and we need to shift that into another area and utilize this money, and I'm sure that would go far down if we cut down, and I'll talk about ICU and other options, what we do at the end of life and what we shouldn't be doing at the same time in the last year of life. In the United States, we're 2 times likely to die in the ICU, and that's a shame, because, when we get to that point, we should have already talked about it, and we shouldn't, be in the ICU is for, it's acute care. It's not for terminal illness care, and that's not where, things like hospice, CPR, should or shouldn't, because that's an emotional area, emotional time, and that's geared more toward acute care, reversing things that aren't at the end of life. And I think as a physician and as the public, we need to get better in recognizing this is not the place. We need to be discussing these things earlier. And also studies have shown that, in the last, we've added about 1.5 years, not 1.5 years to our lives with what we have in a lot of our treatments that we give people toward the end. We're not really making them live better, and you always wonder about the quality of life too, the functionality. I mean, sometimes we do more problems, or create more problems than we do good. Caregiver support, I want to emphasize, we always think about the patient, but the poor caregiver support. I just saw a lady yesterday, a patient of mine, years, her husband has severe Parkinson's, is just progressing. She takes care of him, and she has no family here. And, she's just drained. She's depressed. I mean, 60% depression. 70% economic issues. They can't work, not off work, and it's just very costly. And 63% higher mortality in these caregivers because of all this stress. We need to praise and respect them, give them a hug. I referred her to the Parkinson's. Unfortunately, I always go, do you have a spiritual relationship? And I leave it kind of wide open, and she says no. And it's very unfortunate. I said, because you can go to churches, membership to help you, give you some respite. So I gave her 2 or 3 names of some local care homes that she maybe could have her husband go in for 4 or 5 days to spend so she could get away and do things. And then call the Parkinson's Foundation, or they may be having some people that can help her get away, because she's just tied down. And the caregivers go through so much. And then after death and after passing, it's amazing the caregiver stress then, because you think, oh, it's really, no, they have been caring for somebody for so long, they've forgotten themselves, and they just go downhill. And and a lot of times they don't know what to do. They can't sleep because they've been up and down all night, 8, 10 times a night. That's what she tells me. So there's a lot of things caregivers, we have to respect that and try to help be better in the caregiver support that we do. These are 3 cases that I actually have had over the past, I think this one here was, I don't know, it was in the last few years or so. This is the best way. I'm going to give you 2 bad deaths, and I don't take blame for them, but I'm going to go in and say, hey, this is what could have been done better and what couldn't have been done better. But this is a case when an 80-year-old former engineer, and he had end-stage dementia. About a 7-year progression, mental, physical deterioration, just went downhill. Good. Family supportive and involved. Great. Had advanced directives and medical power of attorney already set up. Great. Had no CPR, don't want a ventilator, don't want feeding tube desired. Great. Easy. Palliative care, initially was seeing him in the early phases, and then when he started going down here the last 6 months, converted to hospice. And we'll talk a little bit about palliative care and hospice. And then he passed peacefully, comfortably at home with family and medical, spiritual needs, social needs, grievance support for family post-death. Everything was just picture perfect. That's the way we would like to see most things. Obviously, sometimes it's impossible to have that. Not so good. Case 2, a 58-year-old laborer, smoker, alcoholic history, 3 months symptoms of esophageal cancer presented. He had metastatic disease. After we presented in the emergency room, no doctor. Assigned to the emergency room doctor, which was me. Had no idea, of course, no advance directive. Family was in total disagreement with what we were telling them. After we biopsied it and said, look, we got to look at comfort care because it's all over the place, and we really cannot help him, with this type of problem. And we had recommended hospice and for the treatment plan. Well, they totally rejected it. The wife says a miracle will happen. Well, sure, I believe spiritually that things can happen. Great things could happen, but being realistic, but we want, and they would say he would want everything done. Well, we had nothing in writing. If we had an advance directive, we'd know exactly what wanted to be done. Children say, if you don't do everything, we'll sue. They were totally not agreeing with anything, and so anyway, he deteriorated. He was placed on a ventilator, dialysis, and the whole 9 yards of everything that goes on the ICU, and he died after 2 weeks. We did get an ethics committee consult 1 day before his death. Probably should have gotten that earlier. But we tried to get hospice going. Unfortunately, he had no doctor, no relationship with anyone. New relationship, had no trust in me. The family didn't know me. They disagreed. He had no medical directive. It was just not, it was the worst setting possible. And so anyway, that's the worst one. Here's another one not so good. 64-year-old with end-stage metastatic bone and liver cancer. Refused, his patient, I talked to him, I said, look, we need to get hospice in on this. He refused it. No, I can do it myself, but I want to treat myself, give me about pain medicines, keep me comfortable, let me die at home. It's good you want to die at home, most people do. I do not want to live like this, He refused hospice until 3 days before death. Well, 3 days before death, that's a bad time because, everybody's emotional. Family, the hospice team hasn't had a time to get in there, and if we had done this 2 or 3 weeks earlier, 4 weeks earlier, it would have been so easy. And he was having severe pain because he was treating it. We weren't able to titrate and do what we normally would do. On high-dose narcotics, delirious, and delirium happens toward the end of the death anyway. But the family wasn't educated into what to expect, and that's what hospice does too. It's an education on what the transition phases as people go through at the end of life. And the family was upset, in no spiritual direction. We had no clerical. And that's sad, because it really breaks your heart. But when you have some spiritual guidance and some spiritual, relationships, it's so much easier to deal with death. It's just so much easier. And you have a minister, you have someone there that can help that through the process. Because as I look at, death is much a spiritual event as it is a physical event, And the comment was, one of us friends admit, I wish we were some other state where, like in Oregon, where he could die in peace. Well, that just crushes you, And we'll get into that too, as far as how I feel about that statement a little bit later. But the last two bad scenes. You can just see. But the first one is just perfect, and we can do better as a physician. The second one, I had no relationship. This one, he was just hard-headed, and he thought he could do it. Some people just feel that way. They don't want to be bothered. Of course, you go through phases. Your denial, you don't it's just and then ultimately you end up saying, hey, this is happening, and then let's go hospice. By that time, it was not a good time. That's why ICU hospice referrals is not the right time to do it 2 or 3 days. That just doesn't work well because the setting is just not right. End-of-life management. Okay, our patients in the last days, they have that unrelieved physical suffering, and they have that significant, when I'm talking about emotional, social, spiritual, they have those kind of distress things that are bothering them. And that's why the team of hospice is so important. Palliative care has everything that hospice, but hospice does not equal palliative care. A hospice is more defined as the last 6 months of death in a terminal illness where you remove all the things that won't keep them comfortable. They're unnecessary things that you don't need to be doing. You want to prepare. That's the dying phase. Whereas palliative care, that patient has a very serious illness. It's a team approach. And you approach them sort of similarly, but you help in the disease management. But they still get treatments. They still get, they still can go in the hospital and do different things. But it's more of a long term in a serious disease state. But again, we want to keep that patient comfortable, meet all their social needs, their spiritual needs, and all those in the palliative phase. But the palliative phase many times enters into the hospice phase later on. And it's always good to, I have patients that are in palliative now. They're bad chronic lung diseases, emphysemas, or they've had a bad stroke or a bad congestive heart failure, and they're not ready to die. We don't know when many times. That's the unfortunate thing too. Is of course we don't have that capabilities, but a lot of times we can guess. But a lot of these heart failure patients, you put them in palliative care first, and you chronic disease management, and you watch these patients, and then once they get to where they're in stage, then they would go into hospice. Most patients, and this is the interesting thing that I like, most patients, if you polled, with 75% want a home death. Sounds very reasonable. But only 25% die there. 60% die in the hospital. It's pretty sad. And we've got to do better in designing in our approach as physicians and, the clergymen. I mean, everybody, we have to talk about this, saying, you want to die at home, then let's get it. And hospice is a very good way of dying at home. Hospice allows a greater than 90% satisfaction, less emergency room visits, less ICU admissions, and 42% die at home. And we're going to get better, and the others die either in hospital, but it's better. You have less readmission rates to hospitals if you use hospice care. And that's what's good about it. I mean, you don't spend a lot of unnecessary money. And patients were surveyed, these hospice patients, and just say, what did you like most about your dying process? Not dying in the hospital. I could die at home. I mean, and that's what it's so important. We've got to talk about these things. And a lot of people think hospice, when I talk to patients about hospice, I don't just say, hey, we need to get hospice to see you. I start talking about, how they feel about it. How do you feel about your illness at this point? How do you perceive what's going on? How does your family look at this? I don't want to just say, hey, let's do hospice right away, because I want to let them understand and see how their thoughts are about this, and then try to inform them and allow them and just say, we can make things much better for your family, and you've got a minister, we can help you spiritually, we can help socially, and we can actually make you live longer in hospice. It sounds kind of funny, doesn't it? But studies have shown that people in their last years of life, or last days of life, they live longer in hospice than they do without hospice. And they have a much better quality of life with pain control, just like that one patient who was just miserable, delirious, the family. You have education because, the last phases of, when people are dying, you talk about things that you're going to see this patient, you're going to see them get modeled. You're going to see your loved one get skin cyanosis. You're going to see them kind of gurgle. Their eyes are kind of sunken back, might be open. You're going to see that mouth, we call it the O sign, and you're going to see them have these irregular respirations. And as long as they're educated, it makes it much easier. And we're going to control that pain. We're going to make it easier. But that's where, as a physician, as hospice come in, that's what we need to be doing better. And that's, I really feel strongly about entering these end of life, and I'll get into this a little later too. But we need to, again, the shifting of care, as I said, more from treating a condition per se of giving them reversible medications to comfort and support care. And I say patient and family. The family's in there too. Because you saw those other cases, the family and everybody, they weren't on the same screen. Palliative care and hospice can be started in the ICU, and unfortunately in the last 3 days of life we see that too much. And that's the wrong place. Because that's an emotional time. It's, the ICU usually see what's going on in there, and you can't get in, you can't stay. The best place, if you're going to do it, get them in a private room, do it. But the best place is at home. Have it set up beforehand. Talk it out. Because the ICU, you're going to see so many things going on. As a family member, on other people, and then you can't stay in there. And the nurses are not equipped. It's equipped for acute treatment, invasive things. And that's not what you need to be doing in your last days of life. It's just totally wrong. CPR. We need to talk about CPR before you get in the ICU. That's the worst place to talk because everybody's, I can't think about that. It's just, but you make that decision and tell your family what your loved one or your power of attorney, whoever you designated, what you do. I do not want CPR. CPR in the last dying phase, it hurts people more than it helps them. Only about 5%, so let's see, I think I have a slide, I'm going ahead. it's not on that one, but about 5% of patients who have cancer or in the last phase, they make it, okay? And as a general rule across countrywide, about 15% CPR. But the problem is like a cancer, somebody who's in the stage dying, you know, you crush ribs because they're so fragile. You do so many things that you don't want to do, I mean, when you're doing that. And you also, you know, you're probably going to have some effects of the low oxygen levels during that time. And they're certainly not going to be better at the end. And it doesn't really add benefit to life. It actually harms them. So we strongly are against CPR. Nice things about like hospice, we have comfort care order sets. We have these sets. There's a good website, UAB Beacon, UAB, University of Alabama, Birmingham, Beacon. And you can find about everything you want about how to deal with death management, but it's UAB Beacon. But it has all these things for physicians and the public, how to deal with the last phase of life, after, and what to, you know, I mean, it's just a very good website that they've developed for this, I mean, for the end-of-life care. And the nursing care shifts. As I said before, we shift, you know, from trying to reverse things to assisting physical, emotional, and the spiritual, the practical, and all these things. And that's where everybody comes in as a team. You know, from minister, I mean, all these things are so important. And your preparation of these families, and that's where the UAB Beacon Project website, as I said. And then care does not end at death. You know, there's so many things that people, the needs after somebody dies, you know, just like, you know, I have people, you know, it's like, here I am, I'm a caregiver. I've been doing this all. We need support systems. You know, you need, and that's where hospice can be helpful. There are support groups and that, you know, and centers that can deal with this. It's just so many things that we can do after, because that caregiver really gets shut out. My father died in his early 50s of cancer. And I remember my mother, you know, after she died, she lost 40 pounds. You know, I thought, oh, she's got something horrible. But, you know, she was just, she was alone. She didn't cook, she didn't eat, she wasn't doing anything like that, and she got depressed, you know. So those are things that we've got to be on the lookout for. But that's when I say, hey, you have a spiritual family, and that's the good part. If you've got a spiritual family, it's so much better. And, you know, it's just night and day in dealing with it. Again, we discontinue all the non-essential drugs, medications, and shift to the as required in the later stage of dying. You know, you don't want to be giving them warfarin, Coumadin, a statin. You know, they've got end-stage Alzheimer's. You know, Alzheimer's. Just stop it. I mean, that's just another pill you got to force down them and make them uncomfortable, and it's not going to change anything. So just the less pill, and only use as required. The pills that's going to help the nausea, the anxiety, the delirium, the comfort. Those are the things that you want to be treating at that last phase. As I said, the breathing, secretions, the delirium, cyanosis, the dreams. It's interesting. About 60% in the end of the stage of life, dying, they have dreams, and some of them are very vivid. You know, I mean, it's interesting how they have dreams, and some of them talk about different things of, you know, relationships, seeing people who maybe they're going to see at an afterlife that they think, but there are some vivid, I mean, dreams, and it happens, and it upsets people sometimes when sometimes they're not so good, and they found like people who have a lot of PTSD or post-traumatic stress disorder problems before, they have violent dreams, you know, because things come back. But it's very interesting in this dreaming phase. But there's a lot of delusions. Things are you know, doing things or thinking things that are totally out of touch with reality. But it happens. But educating patients and, hey, this can happen. That's when we use your Haldols. You do things like that to suppress those, because, you know, that's very upsetting. But if families know what to expect, it's much better. And that's why education, you know, before the end-of-life events happen like this. We need advanced directives. Only 30% of people have advanced directives. And again, right in here, there's advanced directives here. It's in there. I mean, that's sad. I mean, you know, and unfortunately now as a physician, I get reimbursed because it takes time for me to sit down and talk to people about the end-of-life issues. Do you want this, this, and this? When I'm seeing somebody in 15 minutes, you know, they expect me to do a lot. But I do have that. Now they will pay me if I spend that time and set up this, and I give them this book. I have these books in my office, and I hand it to them, and we get reimbursed a small amount for spending that time, because you know, it's just so important. I mean, because as I said, you know, that's the billions of dollars that we waste, and I say waste. We could better spend it on helping them in other ways, instead of you know, and just say, what do you want? Do you not want to have CPR? If this happens, if you can't make that decision and you designate someone else, If you can, do you want to have a feeding tube? Do you want to be put on a ventilator? Do you want those things in case you, people do. I mean, I have people, I say, look, if I'd never want that. I said, no, if you have a broken jaw in your car accident, we'd put a feeding tube down you if you couldn't swallow. I said, short term, yeah, but long term, you may not want that, and that's what you have to think about. If you have a massive stroke, if you have a massive heart attack, you have an oxygen injury to your brain, do you want these things? I said, I said, I'll do either way, but I said, you have to think about this and discuss it with someone else and have it designated. That's what's so important about it. As I said before, 5% cancer in the cancer patient, only 5% survival rate when you do CPR on them. It's not the right thing to do. Visit CPR early in the illness. Talk about these things. Even everybody should. I have a durable medical power of attorney. I have an advance directive. I mean, I've seen enough. My wife, I guess, 3 years ago, we were walking across the street after a ball game and turned around. She got hit by a car. Broke several bones, pelvis, and head injury. I saw her go up in the air, come down, hit her head 8 times. I thought she was dead. Fortunately, she lived. I think she's smarter now than she was then, but don't tell her that. But I said, she's okay. So anyway, but things happen, and here I was sitting on the street and I was looking at her, I go, oh my goodness, she's going to die. And and what happened in like seconds when I turned and saw the car coming, and it hit her, and it happened so quickly. It's probably over in 2 seconds, but that seemed like 20 to 30 seconds. It was so vivid. Going up in there, coming down, landing on the car, sliding off the car like a sheet of ice, and then bang, bang, bang her head. And you just sit there and you just, you scratch your head, go, why? But it happens. It can happen. That's why you have these medical directives. If she had had brain injury because I'm her power of attorney, I wouldn't have wanted her. She wouldn't have wanted that because she's told me that. It would have been easy for me to decide rather than not having anything. And in the ICU, and the doctors come out and say, look, they're probably not going to make it. Do you want to do this? No, she wouldn't want that. And I could tell my kids, she decided this. So it's in there. We're not the ones. So it's better to have something set up because, like I said, I would have never thought that night that was going to happen, but it did. Okay, but when I look at what we have available for me that I can do better to treat end of life, what is necessary at the end of life, and we'll go into what is happening in other states and other countries. I'll go into that and see my views from it as a medical professional. But I do think hospice and palliative care are my approach to end of life care, and I must be better in getting people involved, educating people, getting them to do it, because I think it is the best way to do it. More and more oncologists and people who deal with this on a day-to-day basis, they're getting away from believing in favor of, say, things like euthanasia or, as far as active patient-assisted dying. They're going more toward this because this can keep people comfortable. And we'll get into why people choose to go to take some type of euthanasia or voluntary assisted, say, suicide or patient dying, why people choose this. Again, I'm not an advocate of it, but we're going to discuss it because we cannot bury our head in the sand. You're going to be approached by it. I get approached by it. I got to know what my response is in a way that, is an educated way to deal with it. Two different types of concepts of euthanasia and the physician-aided death or aid to dying. Some people call it physician-aided suicide. Euthanasia is the actual act of me going to the room. I have something, a needle with some syringe, go in and actively do it myself in a consenting patient. That is not legal in the United States. It's legal in Belgium, Netherlands, and up in there. That is an active process of what would be considered euthanasia. And it's an intentional. Whereas PAD, I get tired of these, these acronyms. There's so many. There's PMS, you name it. But PAD and PAS, they're sort of equal. My feeling is the physician-aided aid to dying, to me, is more acceptable as a physician than physician-aided suicide. Suicide sort of involves more of a mental, connotation if you think about it, whereas the aid to dying, it doesn't so much, but they're pretty much synonymous in how we look at these things. It's the act. Okay, I write a prescription out. Okay, and I give it to a patient who has said, hey, I'm 18 years old, I am competent, I have a terminal illness, and I want to die. So that patient takes it, runs with it. The physician is not there. They go home, and then they perform whatever was prescribed or in the act of doing this. It's not, is it intentional? Okay, well, it's there. And we're not here to debate that, but it's just to think about this. And that is what is legal in the first, the Death with Dignity Act was passed in 1997 in Oregon. Washington, Vermont, and California, and now Montana. So there's, those states allow not the euthanasia as defined by the doctor injecting intentionally, but it's prescribing or telling him how this could be done. That's legal. On an 18-year-old, that's legal. Now and so anyway, there's a lot of debate going on right now, and even in the states, of course, as I said before, it's not going to get someone elected right now because that's not a major political platform policymaker issue right now. But it's out there. It's going on. I mean, they're doing it in Jeff City right now, and people, advocates for this type of dying process, and so it's out there. Now the findings, whether in this book or not, you think, well, the patients are demented, but the majority of patients are cancer patients. But what is very interesting to me is the general public support this, and they say it's only to relieve mainly unrelieved pain. That's their main reason. But this is the public. But the patients, totally different. The patients, they're saying, hey, I'm depressed. I've lost all my autonomy. I'm hopeless. And it's mainly psychological factors that they say they don't want to live any longer, and that's why they choose this. And that's a little bothersome to me because it involves some depressive symptoms. Depression is treatable. And people do get better afterwards, after you treat the depression. I'm not saying that, and again, that person, they're thinking about things, but, it does involve those patients who are actually suffering. It's more depressive types of, and that's why they chose this form to die. And that just got me going here, and again, when you give a talk, and I always say, to medical students and like this, or like a church, or the people, you always learn things that you're the one, the person presenting is a learner, because you learn so much, and it makes you think, and that really kind of got me there. And despite the global legalization of this that's happening, you think, oh, it's happening. Well, it is increasing, fortunately or unfortunately, however you look at it, but it's at a low rate. In the U.S., the physician aid to dying, like in Oregon, it's less than 1% of total deaths. It's happening. Again, I'm not presenting this to advocate it. I'm just informing you. In the Netherlands, well, 4%, less than 4%. In Belgium, less than 7%. Of those who are dying have this mode of death. And this was bothersome. I think Jeff and I were talking about this. I said just this past week, and I was reading where an 8-year-old, they just passed it in Belgium, that under the age of 18 and demented patients, dementia, they can get euthanized. And they just euthanized an 8-year-old in Belgium last week. I mean, it's sort of where you draw the line and all those things. But again, those are figures. These low figures suggest that these methods of dying, to improve in life, really aren't chosen by the majority of decedents. But then I ask the question, well, they're just not being reported. More is being done. And that's what's the scary thing down the road. If you don't, there's not going to be things that are being reported, so more and more to be done, and then that leads to some other things that I'll get to later. Again, we should be emphasizing improvement in our symptom control now and our hospice and palliative care at end of life. I want you to know that that's my feeling. Okay, let's see, did I go? Okay. Oregon figures. These are some figures of just 2015 Oregon. Slowly increasing from 1997 when it was originally passed. Again, they do, that this is more of the physician-aided dying or physician-aided suicide. And it's legal for a physician, like I said, to prescribe to a consenting adult with terminal illness to self-administer that. And again, it's self-administered, okay? Of the 10,000 total deaths, I think, that year, 2014, at that time, 38.6, not percent, 38.6 per 10,000 total deaths was done in that matter. So not a lot, but probably too many. And the leading causes were cancer, heart disease, and ALS. Lou Gehrig's disease, where people just told me, it's a sad thing to watch. It's a neurodegenerative disorder where people, they lose everything, all movement, and eventually lose all their swallowing and all their brain, and it's kind of a locked-in dying process. Horrible, horrible. But those are the three main areas and heart disease is taking over the ALSs. There was someone who just moved I was reading an article in 2014. Someone had moved to Oregon January the 1st from another state where it wasn't being done, and stayed there, and about 11 months later they had this form of death. So, the people move there. It's just like I kind of joke with people now. I said, well, yeah, the Colorado, the University of Missouri's attendance at colleges is going down, but Colorado's going up because they can smoke pot out there now. But I'm just saying, because that's what happened. Well, now everybody's going to go be moving there. And the interesting thing I was reading about California's law is that when it was passed, it required 3 statements. And like I said, I'm not an advocate of it, but it made a little more sense that because, if you're depressed and you say, hey, I want it done, get it done, well, that's a sudden decision. But it requires a 15-day interval that, number one, you make the request to your attending physician, and then you write a letter, and then 15 days later you have to write another letter, stating this is what you want. So, that makes, I'm not saying it makes sense, but yet, it's something for me to swallow a little easier. That there is more thought processes and it's not a sudden thing which, can get us in trouble. Interesting is that of these patients in Oregon, 92% were in hospice. So, that's just considered part of it. And I still feel that in hospice, you can relieve pain. You can relieve pain without going through this. And again, their main reason for doing this was reduced life enjoyment, hopelessness, loss of autonomy, and it was not pain in Oregon. It was not the pain were the leading reasons for this mode of death that they chose. And that's a little surprising to me. I mean, I would have thought, well, it's underneath pain, from poor guy, just so much pain. But no, and a lot of those are more depressive type symptoms. Yes, I can see how people get depressed. About 2 years ago, and Jeff, I thought I was told I had cancer by 8 specialists. And so I went in, I conceded that if I thought, well, my practice is going to change. Of course, the worst thing, I had a patient 2 days before I went to the hospital. He says, is kidney cancer, is that hereditary? And I said, what do you say? He said, well, my brother just died of it, and none of my patients do. And of course, I just looked at him and I said, what did he die from? Is sarcoma. And that was what I was worried about. This could be a sarcoma. And the word, well, I go, whoa, Doug. And I had already conceded, I'd accepted whatever's going to be is going to be. I can't change it. Fortunately, I went to the hospital, grace of God, and woke up. My wife said, it's not cancer. I had about a 20% chance it wasn't going to be. And it was an oncocytoma, which behaved like a cancer. It grows, but it doesn't spread. And so it's whacked out. I'm clean right now. But you know what I mean. Like I said, we all live, we live in little glass houses and shallow boxes, and things happen. So, what you see somebody, I always say, when you see somebody walking down the street, you have no idea what they're going through. You see them and you just think, oh, it's perfect for them. Yeah, I've had a great life. I've been blessed. Still am blessed. So I was blessed with that. So anyway, let's go ahead and go to the next. Okay, the pros and cons. And again, I say pros and cons. I mean, you could argue each one of them back and forth. It's autonomy. The patient has that right. The suffering patient has a right. Well, yes, they do have rights, and no doubt about it. But you could argue, well, if you do take his life, however, the method by euthanasia or PAD, then you take away his autonomy. And euthanasia has the advantage to relieve the person's pain beneficence. You could argue that too, back and forth. Financial implications of the individual and national economy. What that means is that, people go bankrupt. I mean, medical care is so expensive, and it's sad the way it is. And people go bankrupt. Well, you can prevent that. Can't argue that. I mean, that's the way some look at it. National economy, well, we talked about that $210 billion that we spent in last year's life. We wouldn't be doing that. As trying to be a good steward of care, you kind of say, okay, I understand, but, and insurance companies, well, sure, they don't want to pay for long-term care. They say, get rid of them. That's what could be scary if all this could be legalized. You'd have to a lot of structure this because, It is a slippery slope, and it isn't a slippery slope. Organ harvesting. This was very interesting to me. I mean, I never thought about this. But okay, say you got a patient, and that patient's healthy, hasn't gone down the long path of disease, deteriorated, be debilitated, shrunk down, their organs are collapsing. Organ procurement for donation. If you've got somebody that you intentionally, they lose their life, you can procure those right away in a healthy state and utilize those down the road. It's a thought process. I mean, yes, it makes sense. It does make sense that way. And as opposed to getting to someone who's deteriorated, and and their organs are malfunctioning, are not as good. I mean, that's what some of the pros would say. And it can be used. Wrong frame of mind of the patient. Say they're depressed. They make that decision and they do it, bang. Well, California, at least you've got that 2 to 3 week period. You might change your mind. Maybe you're not so depressed after that. You think about it, maybe you're not going to do it. But in Oregon, they don't require that, at least from what I've read. Older patient demented. Well, you just start, getting rid of people, and it is what it is. I mean, I see dementia. And dementia is a horrible thing. I think of any one thing in our country that we need to tackle right now, because the fastest growing segment of the population is about 60, 65 and over. And dementia after the age of 80 hits about 40, 50% of us. I mean, you know what I mean? I mean, and the cost of that, it's going to be more and more and more, and we're not even on first base right now, I don't think. I mean, we have a lot of research, but the medicines we use are really, they're Band-Aids, or we're treating ourselves as a physician at best, because it doesn't help that much. And the cost of caring for someone for these 6, 7, 8 years, the emotional, we need to hit that right up front. What causes those plaques? What causes those plaques to go into tangles, and then that mind, they lose all their memory and all their executive functionings, and they're just there? We need to get up front and say, hey, that's where it starts. Right now, we're treating it way down the end. We're not good at it, and we need to get there, and in that way we could save a lot of money too. So there's always a chance. Abuse by family. Okay, well that's another one. Well, you've got someone. Well, maybe that there's some motives that maybe they want to get rid of someone because they're going to inherit a pretty good inheritance, and it might be used in wrong ways. And not all the prescriptions that are written, say in Oregon and these countries, actually end up doing it. I forgot what percent do go through with the process, but they're there. So what happens to those? If you got a wife that's pretty mad at you and you've done something she don't like, don't go to sleep, because you just don't know. I mean, that could happen because you get the prescription from the doctor. It doesn't mean that you got to return it in 2 days. At least I couldn't see where that was said. It could be used in the wrong way, A doctor's abusing it, mercy killing, things like that. The intent, and that brings up, there's something called double effect. When you treat a patient, you give them medication, you know that morphine relieves the pain. But at the same time, it could have some bad consequences if the dosage build up. But your intent, my intent as a physician, is to relieve their pain. My intent is not to end their life. And that's, what you kind of think about. But the intents of some people may not be that way. And it's a frightening thing. We had our Hitlers and people like that. My thoughts as a physician, I've pretty much given you a lot of my thoughts, but it's not legal in Missouri yet. I'm sure there are people knocking on the door trying to get it. And I'm not, I have my feelings about it. I can administer pain-killing meds, that's permissible. I didn't say patient-killing meds, I said pain. I want to relieve that pain in that patient. And if it takes, if I'm giving them morphine, or they're so short of breath or so much pain, my intent is to relieve them and make that suffering much easier and less in that patient. Now, they may die, but that they were in the process of dying anyway. But my intent is not to hurt them or kill them. Competent patient kin, the relatives and their people, especially if you've got advanced direct, they can help us in that decision, what we do and when to withhold treatment. And that's the important thing. And as I said before, to me, death is both a physical and a spiritual process. I think there are things that I don't understand. Obviously, I haven't died. But there are things that I think occur, and I think, you read the suffering that, that our Lord and Savior went through at the end. I mean, that was necessary for us. And there's things that happen, and patients seeing it, sometimes the family seeing it. I think there's, in the binding, but I think in the right environment with control, good support system, it is the best way. And my intent is to help the patient in the natural process. I have spiritual convictions. AMA, this is kind of interesting. The AMA has always been against it. I'm out of the AMA now because I object to a lot of the things that they have done. About probably less than 20% of people don't know this, but 20% of physicians are not in the AMA. That means 80% aren't. We have a lot of disagreement. AMA, again, they just haven't supported. I always say they're a bunch of fat cats that sit up in Chicago and take a lot of dues, and they do things with them that I don't agree. And a lot of I'm with probably 80%, so you know what I'm saying. They do some good things now. But I did have a problem. When I was reading about this, in 2017, they were going to look at taking a more neutral position on euthanasia and the PAS, PAD. A neutral position. Now, against it. Most physicians are totally against it. I mean, most. But there are that do. I mean, agree with it. And I have my issues, but again, there are physicians that agree. And in Oregon, I mean, that's legal, and so that's where, that's it. But so anyway, when a place becomes neutral, where are we? Okay. When a state medical society or a national become neutral, then it's more being apt to being passed. This is from the Hippocratic Oath segment. And I take this when I became a physician. I will use treatment to help the sick according to my ability and judgment, but never with a view to injury and wrongdoing. Neither will I administer a poison to anybody when asked to do so, nor will I suggest such a course. Similarly, I will not give to a woman a pessary to cause abortion, but I will keep pure and holy both in my life and my art. I mean, it's what by Hippocrates, which was considered the father of Western culture medicine. That's what we say. Now, again, that's been, in states, there's been courts that have overruled that, and, it is what it is. But, I mean, that is another reason that I when I say something, I sort of feel that way. And let's see, where are we? Pretty close.